Right, good evening, everybody, and welcome to this open hand webinar that is brought to you in association with the University of the Witwatersrand, a university in Johannesburg, as well as the South African Society of Hand Therapists. My name is Kirsty van Stormbroek, and I will be your host for the webinar this evening. So tonight's webinar, as you know, is about how to manage extensor tendon injuries using relative motion splinting. So first of all, Vicki Hofmann will be telling us about why the relative motion splint works and how to make it. And then Nicola Ehlers will tell us how to implement the relative motion extension program, after which we'll have time for some questions and discussion. You can contact us with any questions that you have using these details. But without further ado, I am going to stop sharing and introduce our first speaker. So, Vicki Hofmann, welcome this evening. It is really, really lovely to have you here. Vicki graduated with me from the University of Cape Town in 2005. She obtained numerous awards in her degree, and I can vouch that she was pretty brilliant. If you ever had a question, you asked Vicki. So she obtained multiple awards for excellence in fieldwork and academics at university. She then completed her community service in rural KwaZulu-Natal, so south of Durban, and I had the privilege of visiting her there at Murchison Hospital, where she worked as a generalist OT. And then after that, she moved to a larger hospital in Durban, again seeing a very diverse caseload. Vicki moved into hand therapy practice in 2008, and she has owned and managed this busy practice for a number of years. Vicki is passionate about advancing hand therapy in South Africa and invests a lot of time in mentoring and teaching younger therapists. She's also served for many years on the South African Society of Hand Therapists, and she also lectures part-time at the University of KwaZulu-Natal. Vicki, thank you very, very much for being so keen to share your expertise, and we invite you to share your presentation with us, and you can go ahead when you're ready.
Thanks, Kirst. Welcome, everybody. It's great to be able to share with all of you. I see there's quite a few of you online, so I hope that this is helpful. And yeah, as Kirst mentioned, please just pop any questions you have in the chat as we go along. So we are going to be chatting through managing extensor tendon injuries with relative motion, and this includes extensor tendon repairs in zones 4 to 7. So first, before we get going, I just want to go through the extensor zones for those of us who need a bit of a recap. So if we look at this bottom hand on the left-hand side, you can see the different zones from zone 1 to zone 7. So we are talking specifically about zones 4, 5, 6, and 7 for this protocol. And why is the relative motion concept? How does it work? So what it does is it places the injured tendon in 10 to 15 degrees of less motion than the adjacent tendons. So the way that I can describe this is, for example, they talk about the pencil test. So if you had to take a pencil and put it between your fingers, that is sort of how we describe relative motion. So you place the one finger in more extension than the adjacent 2 fingers or 1 finger. So how does it work and why does it work? So there was, I'm going to explain a little bit more just now, but there was a guy by the name of Wendell Merritt that did quite a lot of experimenting on cadavers, and he found that when he placed the injured digits in this 10 to 15 degrees of relative motion more than the adjacent digits, there was significantly less force than on the adjacent tendons. And the way I can only describe this is if you imagine that the extensor mechanism is probably one of the most complex structures in the body. So I can't go into much detail. That's a full webinar in itself. But the way that I can explain it in the most simple terms is that it's one muscle belly with 4 tendons that come off that. So if you place 2 of those tendons in slight flexion and 1 in slight extension, you can imagine that the 2 tendons that are in slight flexion are actually putting the entire mechanism on stretch. So the whole mechanism sort of advances distally. So you can, then it puts less stress on that repair site. So I hope that that makes sense. You're welcome to pop some questions if I need to clarify that a little bit more. But because it's one muscle belly with 4 tendons, basically it advances the whole mechanism forward as you place stress on adjacent tendons. Okay, let's go. So just a little bit about tendon healing as well. So you've got days 1 to 5, which is your inflammatory phase. So in the inflammatory phase, that's when you've got your inflammatory response. It's painful, it's swollen, there's redness, and the body works to remove any damaged tissue to prevent infection. So those are your first 5 days. Then from days 5 to 21 is your proliferation phase. During this phase, the body starts to rebuild the tendon. So new collagen fibers are laid down. It gradually regains strength. But these new fibers that are being laid down are pretty disorganized and quite a lot weaker than a normal tendon. So you will have heard a lot of people say that in week 2, the tendon is actually weaker than it is in day 1 to 5. And so that is why, because as it starts to proliferate, it's very disorganized, so it lacks strength. Then in your remodeling phase, which is weeks 3 to 12 and beyond, your collagen fibers are reorganized and aligned along the lines of stress. It regains its strength and elasticity, and full functional recovery can take several months, just depending on the severity of the injury and obviously what treatment is provided. Tendons inherently have a very poor blood supply, which is why they take so long to heal. And it's also why rehabilitation is so important when it comes to tendons. So basically, they gain their blood supply from surrounding tissues, and that is why they tend to stick and adhere, because they want to gain as much blood supply as they can in order to heal. So there are other ways that you can advance tendon healing, things like plasma-rich platelet injections. But yeah, that's basically just a brief overview on tendon healing and why adhesions are so common among tendons that are kept still. All right, so a little bit of an introduction. In the mid-1980s, post-op care of extensor tendons in zones 4 to 7 began to shift from complete immobilization to controlled passive motion protocols. And this was in the form of a dynamic extension orthosis, which allowed protection of the repair while allowing the tendon glide to prevent adhesions. So we all know the splint that we love to make. Doesn't take very long to make, and it's very easy. So we all hate those coming into our rooms. So the dynamic protocols produced excellent results, and compared to their static protocols, because the dynamic protocols preserved flexion and provided glide at the repair site to prevent the significant adhesions that the static protocols led to. Also, with the static protocols, what tended to happen is because of these significant adhesions, you would end up with a loss of composite flexion. So you couldn't get the MPs to flex completely. So the dynamic orthosis, as we know, is bulky. It's time-consuming and costly to fabricate, and it's difficult to wear continuously. I've yet to find a patient that has been compliant with one of those splints. So Wendell Merritt, he came up with a design of, initially it was called the ICAM protocol, which was immediate controlled active motion protocol, which has now been sort of coined with the term of relative motion. So he introduced the digital yoke orthosis, which provided a low profile option, allowing this immediate controlled active motion. So because of this controlled post-op motion, it facilitated excursion or glide at the tendon at the repair site and therefore minimized adhesions. This is what the yoke orthosis looked like, and as you can see, a whole lot easier than making one of those dynamic extension splints. So a little bit of background. Wendell Merritt, he did his first study on cadavers in 1978. So that was when he discovered that the tension on the repaired extensor was, the tension noted on the repaired extensor if the digit was positioned in 25 to 30 degrees more extension relative to the uninjured MCPJ. So that was what I was explaining in the beginning, how you get that relieved tension by keeping that digit in slight extension. And that was how he derived the relative motion yoke orthosis, which allowed this immediate controlled active motion. So the current protocol actually has the wrist orthosis, so a wrist extension splint in 25 to 30 degrees of extension, with a yoke orthosis positioning the injured MPJ in 10 to 15 degrees more extension than the adjacent fingers. I'm going to come back to this in a little bit because that wrist orthosis has been sort of thought to be unnecessary in some of the zones. So I'll get back to that in a minute. So what this does is it allows full composite active motion of all your uninjured digits and 10 to 15 degrees less MPJ flexion of the repaired digits. It does require at least one digit to be intact, and it cannot be only the index or small finger. So for example, if someone's had a complete extensor tendon repair of all digits, we cannot use this protocol. You will have to then do the dynamic protocol. And if it is only an index or small finger left in place, you'll also have to go for the dynamic protocol. So I've written there on the screen the pencil test, which is sort of what I was describing just now. So the way you can check if you can use the yoke orthosis or not is to take a pencil and see. So if it's an index and a ring finger that's been injured, you can take the pencil and yes, you can see that the splint will work. But as you know, if it is only an index finger that's intact, there's no ways that we can hold all three digits up with one finger in flexion. It definitely won't be balanced. Okay, so that's what I talk about when I say the pencil test. All right, so this is what it looks like essentially. So the picture at the top, you can see the middle finger is the injured finger. And then actually in all the pictures, it's the middle finger. That's the injured finger. So it just shows you different pictures. You can see underneath the hand and with the wrist orthosis on as well. I'm now going to try and show you a video of how to make the orthosis. So just before I show you this video, in the video, it's an offered video, which is one of the splinting companies, material supply companies. They are using quite a new material called Orphicast, which I know a lot of people in government won't have access to. But the concept of making it is the same no matter what material you use. He measures making the orthosis with the material, but I just use a tape measure to decide how much material I need. And actually, I made one out of plaster of Paris in my rooms the other day, and it works perfectly. So if you do not have access to splinting material, you can make this with plaster of Paris. What I did is I cut strips of plaster of Paris to the length that I needed, and I put 8 layers of plaster of Paris on top of each other. And it's a very strong, I probably didn't actually need all 8 layers. I probably could have gotten away with 6 layers, but it made a perfect yoke orthosis. So those of you that don't have access to splinting material, because I know that's quite common, that's another option. I'm just going to show you the video quickly of how to make it. So let me know. Let's get this going. Okay.
Yoke orthosis middle finger. Here we will demonstrate a yoke orthosis for the middle finger. This orthosis can be used in a post-operative extensor tendon rehabilitation protocol. It can also be used to restrict motion at one PIP joint and to encourage motion at another PIP joint. Use a strip of 6 cm wide orphicast. Measure the width of the hand's MCP joints and cut the orphicast accordingly. Fold the orphicast in thirds lengthwise. Wrap the orphicast around the first phalanx of the middle finger. Wrap the edges of the orthosis towards the palmar side of the first phalanx of the index and little finger. Carefully mold the contours of each finger into the material, thus making sure that each finger easily finds its place. Let the material harden and remove the orthosis. Round the edge on the side of the index and little finger. The orthosis can now be fitted. This orthosis allows finger flexion, but will protect the extension system of the middle finger during flexion of the long fingers.
All right. Okay. So that's essentially how to make the yoke. And another comment that I wanted to make, so you can see in this one, if you can see my little video, I actually joined and made sort of almost 2 rings. I always used to do that actually with normal splinting material, and like I actually have found it so much easier to make it the way that the video made it, because often the patients got quite swollen fingers and it becomes quite difficult to get the yoke on and off if you make it circumferential. And obviously then as the swelling goes down, then the whole thing slips off. So, and if there's bandages and things, it just makes it a little bit harder to mold. So you don't need to make it circumferential. Quite a few of the videos or pictures of it, even the ones that some of the slides that I shared earlier, they do show that it's circumferential. But I quite like the idea of not making it circumferential, and it is strong enough and it does stay on, it doesn't slip off. So it is probably, and then you use even less material. So I think that's a great way to do it. All right, next slide. Okay, so Dr. Merritt, he started using this controlled active protocol in the early 1980s, so long ago, when other controlled passive protocols were being introduced. And he has since reported results that are equivalent or even better than dynamic orthotic management. So just to review a little bit of the literature. So in 1997, Saldana presented at the American Association for Hand Surgery, and 26 out of 27 excellent results and 1 good result out of his patients that he treated. Hull and Merritt, they presented a 10-year study of 180 patients, and he said 98.5% had normal flexion and 96.2% had normal total active motion. And then in 2008, Berry and Neumeister compared the use of using a wrist orthosis with the yoke or not using the wrist orthosis, and they concluded similar results with or without the wrist immobilized. So that was where I was saying there has been some research to say that you don't need to have the wrist splint, and I think this is particularly important if you don't have access to splinting material. I do think that when you get towards zone 7, when there could be wrist extensors involved as well, the wrist extension orthosis is very important. But zones 4 and 5, you can definitely get away with not using the wrist extension splint. Okay, so in conclusion, the relative motion is safe and effective. It's low profile, it's less cumbersome, and it provides protective functional use, which increases the patient's compliance. It's easier and less time consuming to fabricate with less costs. And Wendell Merritt actually anecdotally alludes to less therapy visits. So he's saying that you don't need as much rehabilitation with this orthosis, which is also great in a public setting when time is of the essence. It does, however, require that at least one digit is intact. All right, and that's the end of my presentation. So I'm going to hand it back to Kirsty.
Thank you so much. Thank you so much, Vicki, for that very clear presentation. I see there are some questions in the chat, which Vicki's going to have a go at while we introduce our second speaker for the evening. I'd like to introduce Nicola Ehlers. And Nicola, she graduated from as an OT from Wits University in 2010. Hello, Nicola. She received awards at university for her academic performance, as well as a research award from the Occupational Therapy Association of South Africa. She did her community service in a Gauteng sub-district, so in the community. And for the last 12 years, she has worked in the public sector at Leratong Hospital in Gauteng. After obtaining her postgraduate diploma in hand therapy in 2017, she's worked almost exclusively in hand therapy, although she remains very familiar with the challenges of working as a generalist in a low-resource government setting. This webinar series that we are doing is essentially Nicola's brainchild, and it's been Erica and my privilege to work with her on the Open Hand Therapy Initiative. Thank you very much for being willing to share on this topic this evening. Nicola, over to you.
Thank you. Okay, so I'm going to talk about how to implement the relative motion splinting for patients. And then I've also included some information on how to deal with some of the challenges that are commonly faced where I work. We're going to start with that case study. So we're going to call him Vincent. He is 29 years old. He's right-handed. He works as a security guard and he stays alone. So he was stabbed with a broken bottle on the dorsum of his right wrist during a fight. So generally, if a patient has a single laceration, then all the tendons in that area are going to be cut. But broken bottles, as you can see in the picture, have very jagged edges. So because of those jagged edges, you can get patients with fingers, tendons damaged that are not in adjacent fingers. So this was the case with Vincent's. So he had lacerations of the extensor digitorum tendons of his index finger and his ring finger, but the middle finger was actually intact. So you can imagine that our splint is going to have to look quite interesting. So tendon injury should ideally be repaired within the first 7 days or so after the injury. But where I work, that's not always possible. Vincent had to wait for 2 weeks just to be admitted to hospital or for a bed to be available for him. And then he had to wait for another 2 weeks before he could have surgery. So with time, the tendon ends start to pull apart or retract, and the tendon ends also become soft, and that soft part has to be debrided. So you can imagine that when he does have surgery, it's going to be a lot more difficult. The tendon might even end up being repaired under more tension than it ideally should be. And if there's too much tension on the extensors, then regaining flexion is going to be more of a challenge. So we're expecting more edema, we're expecting more difficulty getting the hand moving, and possibly even a poorer result in the end. So when to start? For the first 3 to 5 days, the patient is in the inflammatory phase. So they're probably going to be complaining of quite a bit of pain, the hand will be quite swollen. So during this time, we really just want them to rest and to elevate the hand. This is going to help the swelling to go down, so there's not so much resistance when they start to get the tendons moving again. So around 3 to 5 days, they're now entering the fibroplasia phase. Collagen is starting to develop. We're going to hope that the edema and that the pain is improving quite a bit by now. And now we can actually start with making the splint and with doing some exercises while wearing the splint. So for protected motion, there are 2 things that are very important. The first is that we need to avoid overstretching the extensor tendon by moving the fingers into full flexion, because that's going to pull the tendon apart. But as Vicki explained, the splint is going to help us to achieve this. Then the second thing is that we need to avoid excessive pull by the extensor muscles. So for example, extending against resistance. So these are the most important precautions following a tendon repair, because either one of these things could cause gapping or rupture if we start with this too early after the repair. So in the first session, patient education is extremely important. So I usually spend quite a bit of time just educating the patient before we even do anything else. So I want them to understand what a tendon is. I want them to know what a tendon injury is. I want them to know what to expect. So like, how long are they going to take to recover, what the process is going to be. And then I also want them to understand the importance of following the program. So they need to know that if they take their splint off and use their hand however they want, they are going to be at risk of rupturing the tendon, then they're going to need surgery again. But at the same time, if they don't do the exercises like they should, the tendon could get stuck. Then we can also ask the patients about their activities and participation. So here we want to know, what do they do at home? What is required of them? And if they stay alone, then I get a bit worried. I want to know, like, do they have someone who they can get to help them with the things they are struggling with? And then, are they working? Is the employer aware of the situation? And what are the requirements of their job? If their job involves heavy work, are there maybe some light duties that are available for them before they're fully recovered? So as I already said, Vincent works as a security guard. So he stayed alone, but he'd actually already moved back in with his family before the surgery, because while he was waiting for a bed in the hospital, he wasn't actually coping by himself. So at this stage, all that's actually required of him is to do basic self-care. But his goals are to get back to work and to live independently again. So the next thing that we are going to do is we're going to make splints for Vincent. So you can see here that I had to be a bit creative with the splints, because I wanted to make sure that I got that index finger and the ring finger in more extension than the index and the ring finger in more extension than the middle and little fingers. So at this stage, we really want the patient to be wearing that splint all the time. I usually tell them that they can take the splint off if they maybe want to wipe the hand or if they want to look at the wound, but they shouldn't really move their hand without the splint on. And we also need to make sure that they know how to put the splint on correctly, because if they put that splint on upside down, they could really do some damage. So Vincent's first exercise is going to be active composite finger flexion and extension within the splints. So this is his range of motion just after I made the splints for him. This is not great range of motion. Most of my patients can do better than this at the beginning, but we must remember Vincent has had a tough time already with his surgery being so delayed. So I encouraged him to work on this. I wanted to see if we could get some improvement by the next session. Then you also need to manage the edema. We can check the wound. And the patients at this stage can use their hand for light activities. So we've already asked Vincent quite a bit about what sort of things he does at home, so we can give him very specific advice on what is safe and not safe to do with his hand. So this is the original protocol. It's divided into 3 phases that have different requirements for splinting and also specific aims that we want to achieve. So we're going to be using this as a guideline to treat Vincent. But it's important to remember that protocols really are just guidelines. We may need to adjust these guidelines in order to get the best results for Vincent and for our other patients. But we'll go through the treatment phase by phase. I'll explain what I did with Vincent, and I'll also give you some other ideas that you can use for your patients as well. So we're going to start with phase 1, the first 3 weeks. During this time, the patient needs to be wearing both splints all the time. So I usually check with them in each session just to make sure they are managing to wear both splints. We need to continue with edema management if the hand is still swollen. And if the swelling does decrease, then we can look at adjusting the splint if it's not fitting that well anymore. Then once the sutures or clips are removed, we can start with scar massage. So this is Vincent the week before and then straight after his clips were removed. So you can see this part here is the original wound. And then this is where the wound was extended by the surgeon when he repaired the tendons. So this part is looking really good. It's ready for scar massage, but this part was a bit open, so we delayed it a bit with that part. Then it's also good to check how the patient is coping with ADL. Vincent said he was managing really well. He was independent now in basic self-care, and he could use his right hand for light tasks. If the patient does light work or if they can do light duties at work, then already by the end of this phase, they can look at going back to work again. So Vincent could return to work at about 3 weeks. As a security guard, he had to patrol a designated area and he had to do a minimal amount of writing, so he could manage fine with that. Okay, then we need to assess how the patient's range of motion is progressing, and then we can revise the exercises accordingly. And it's always good to ask the patient to show you how they are carrying out the exercises, so that if they're not doing it right, then you can correct their technique. You can also ask them how often they're exercising, so that you can increase the frequency as needed. So this is Vincent's movements after 1 week. You can see it's improved a lot since the first session, but we can still do some work there. So what we're aiming for in this phase is to get full composite finger movement in the splints. So let's see how we can revise Vincent's exercises to achieve this. Okay, so here are just ideas for exercises for phase 1. So the first one is active composite finger extension. But you can see Vincent is struggling to extend his fingers, and you can see his MP joint flexion is not looking the greatest. So I got him to do flat fist to work on the MP flexion and then hook fist to work on the extension. Hook fist is an important exercise with these patients. Sometimes if they try composite extension, what happens is that the intrinsic muscles, which are working completely fine, weren't repaired, don't have any problems, they contract first. And these muscles are very good for extending the PIP and DIP joints, but they actually flex the MP joints, making it a lot harder for the patient to get that extension. So if we get them to flex the IP joints and then extend the MP joints, what this will do is it will help them to isolate those extrinsic extensors and get the tendons gliding properly. You can also do place and hold composite finger extension with the IP joints flexed or extended. And it's important to check the PIP joint extension. So you want to see if there's any stiffness or tightness in those PIP joints. And if there is any stiffness or tightness, then you can do some passive stretches to address that. But for Vincent, this wasn't a problem. And we're also going to continue with scar massage. So you can see Vincent's scar is improving in appearance, but it was still pretty stuck. So according to the literature, patients should be coming every week for follow-up. And if they can do that, that's great. But this might not be realistic if they're coming from quite far away. So I really want them to come back after 1 week because I need to see if the splint still fits properly, if they're wearing it properly, if they understood the exercise program properly. And then in my setting, they also come back 2 weeks after the surgery. That's their follow-up with the doctor when the stitches are removed. But after this, Vincent wasn't able to come every week anymore. So when patients come in frequently, we don't have so many opportunities to check that they're doing the exercises like they're supposed to. And we also don't have many opportunities to see if we need to change the exercises if things are going wrong. So in this case, patient education becomes very important. Patients need to know exactly what they're supposed to do in the periods where they're not coming to see us. And then we also need to act quickly if things go wrong because we know it can be a bit of a while before we get to have a chance to change the program again. Okay, so now we're in phase 2. Vincent has reached week 4. This is what his movement is looking like. So you can see that finger flexion is looking really, really good. He has full flexion of his fingers, except for the bit that the splint is stopping, which is how it's supposed to be. His extension is much better, but you can see that ring finger is still not quite extending properly. In this phase, we want the patient to still wear the finger splint all the time, but they can start to take off the wrist splint for light tasks. And you can keep on educating the patient on what is a light task, what is a heavy task, what is safe and not safe to do with their hand. Then we're also going to start with wrist exercises now. So Vincent had full active wrist extension, but as you can see from the picture, wrist flexion was a bit of a challenge. And our aim here is to regain full wrist movements. So some exercise ideas. Here you are going to continue with the previous exercises as needed. So for Vincent, we needed to keep on working on that composite finger extension. Then, as I said, we're going to start working on wrist range. And flexing the wrist can be quite dangerous for an extensor tendon repair because it puts a lot of pressure here. The tendons get quite stretched out over the wrist. So it's important that the patient extends their fingers to relieve the tension. Then the same thing, when they make a fist, the tendons are stretched over here, but then if they extend their wrist, then the tendons are relaxed at the wrist. So they need to be exercising the wrist like this to begin with, and this is called wrist tenodesis. If they exercise like that for a bit and you see that they are doing well, they're not developing any extension lag, then you can move on to passive composite wrist and finger flexion, and also active composite wrist and finger flexion, active composite wrist and finger extension. Okay, so now we're on to week 6. The patient is now properly in the scar maturation phase, so we know these tendons are getting a lot stronger. We still want them to wear the finger splints, but they can now start to take the splints off when they exercise, and the wrist splint we don't need anymore. So this is what Vincent's hand was looking like at week 6. So I was very happy with his finger flexion, that looked great, but the extension you can see is still a problem. I was measuring his fingers, so I could see that the extension was improving, but it wasn't quite there yet. His wrist flexion was also improving according to my measurements, but you can see composite active wrist and finger flexion was still quite a challenge. Okay, the scar is looking better, but it was still very stuck. So in this phase, our aim is to regain full composite finger and wrist movement out of the splints. So let's see how we can revise Vincent's exercises in order to achieve this goal. So the main exercise for this phase, if we look at the aim, is to do active composite finger flexion and extension without the splints. We can also do flat fist and hook fist without the splints. But chances are, after 6 weeks, Vincent is probably getting a bit tired of these sorts of exercises. So maybe we can be a bit more creative. So his main problem is that ring finger extension lag. So extension lag means that the passive extension is fine, but the active extension is decreased. So this is because his tendon is stuck or adhered here where it was repaired. So the muscle can't pull the tendon through fully. So the best way to fix this is to get the muscle to keep on pulling and pulling and pulling until it loosens the tendon and the patient can get full movement back. So you can see that active finger extension is going to be very important. So one way to work on this is to get the patient to put their hand on the table and then actively extend the fingers. So you can see this man also had a ring finger extensor tendon repair. Some patients might not be able to extend their fingers much, like this man in the video, but they'll still feel that tugging, which shows this is a very effective exercise. Then you can also get patients to try scrunching a towel. So what I like about this is it encourages MP hyperextension and then the IP joints are flexing. So this is Vincent giving a go at the towel. You can see it is quite a challenge for him, especially for that ring finger. Okay, then at this stage, the tendon is also strong enough that we can start with gentle passive flexion of isolated joints. So if stiffness is present, I usually find that it's in the MP joints that's the problem. So we want to get the patient to put the wrist in a relaxed position, the IP joint should be extended, and they can gently work at flexing the stiff, passively flexing the stiff MP joints. But for Vincent, this wasn't a problem. And you can continue as needed with scar massage. Okay, so now we're at week 7. We kind of finished with the protocol as it's been described. We can stop with all splinting, and most patients will be ready for discharge by this time. They should be coping well at home and at work, and they might not really need any further exercises. But if the patient has decreased active movement at this stage, that indicates that they have adhesions, which are restricting the tendon gliding. So introducing resistance will be important to put tension on those adhesions, which is needed to improve the tendon gliding. So as you can see, Vincent was doing pretty well by this time. He was managing with everything at home and work. He was completely independent. But I felt we could potentially do a bit better, especially in addressing the tendon adhesions of his ring finger. So tendon adhesions is going to be the most common problem that you're going to face when treating tendon repairs. So we need to understand what a tendon adhesion is and how we can address them. So I don't know if it helps, but this is a picture that I found of what a tendon adhesion looks like. So this is a rabbit, by the way. So you can see over here, this is where the tendon was repaired, and then all of this here is the tendon adhesions. So you can imagine that if the muscle contracts and it pulls on the tendon here, then it's actually mostly going to be pulling on these tendon adhesions. The muscle could probably pull quite strongly actually, and all that would happen is that these adhesions would stretch out, and that's exactly what we want. But now imagine that these adhesions were not here. If the muscle pulls without the adhesions, then it's going to be putting tension directly through the tendon, and it's going to be putting tension here where the tendon was repaired, which puts the tendon at some risk for rupturing. So if the patient has good active movement, then we know that there are no restrictions from tendon adhesions, and we know that if we add resistance or strengthening exercises, then we're going to put tension directly on the tendon. So in these patients, we need to be more careful with introducing resistance, and we may not even need resisted exercises at all. But if the patient still has decreased active movement at this stage, then we know they have tendon adhesions, and we know that they need resistance to help to get rid of those adhesions, to stretch them out and to improve tendon glide. If you add resistance and the patient still doesn't improve, then you can add even more resistance. When the active movement starts to improve, then we know that the resistance is working, but we can just keep on increasing it slowly over time, because we know that with time, the adhesions are going to become more and more fixed. So if we do need strengthening or resistance, then we can often do this using objects that the patient has at home. So for strengthening finger extension, they can use kitchen tongs or large scissors, and they can put an elastic band around the end. And I even get them to pick up different objects with the tongs so they can see how they're improving. The difficulty can be increased if you wrap the elastic around more times, or if you move the elastic further away from the hand. So Vincent wasn't so sure if he had kitchen tongs at home, but he told me that he definitely had a big pair of scissors, so he was going to go home and exercise with that. For grasp strengthening, I often get patients to start by squeezing a towel, but as their strength improves, they can also use jumper cables. I quite like using jumper cables because it's something that a lot of people who have a car will have at home, and if people don't have a car, they can often lend from a friend or relative. You can also use other clamps like these ones. They tend to be cheaper than those hand exercises, springs, or gadgets, and the patient can also measure their progress by how wide they can open the clamp. Then you can also introduce composite flexion stretch, so you can get the patient to make a fist, flex the wrist, and then provide some passive pressure there to really stretch out those extensor tendons. So the aim here is return to normal function. So I didn't actually see Vincent again. He defaulted his next appointment, so I don't know what his final result was, but I think the reason he defaulted is because he felt that he had achieved this aim already. Then quite a few of you asked how to deal with patients who are not referred on time. So this is a problem that I encounter as well, and I feel like it definitely affects the patient's outcomes. So if we start a few days later, the patient may have more difficulty regaining full extension. But if it's even longer than this, they're going to have persistent edema that's hard to get rid of, the joints will already be stiff, and they'll already have some tendon adhesions. And that's really going to make the rehabilitation more difficult and also more prolonged. So if the patient is referred at 2, 3, or even 4 weeks, then I usually still make them a relative motion splint, but I won't necessarily make a wrist splint because they're probably at or almost at phase 2 where the wrist splint isn't needed anyway. And then what you can do is you can follow the same guidelines that you would depending on where they are. So if they're in week 2, they're phase 1, you're going to follow the phase 1 guidelines. But you're going to check and see if those guidelines are working. If they're not working, then you may need to advance through the guidelines a bit faster in order to still get an acceptable result. And if this is something that you experience often where you work, then I would really encourage you to speak to your surgeons and see if they can refer patients more on time. Here's an example. This patient was referred 2 weeks post-surgery, and his surgery was really delayed, which also really didn't help. So you can see that his MP joints are already very stiff, and he has a lot of tendon adhesions. So as you can see, I made him the splint, and then because he was 2 weeks post-surgery, we started in phase 1. So we did phase 1 exercises. I specifically emphasized flat fist because of the MP joints being stiff. But when he came back, there wasn't really that much progress. So I could see that we needed to up our game a bit. So in special circumstances like this, you can start passive flexion for stiff joints earlier than 6 weeks, but you need to be absolutely sure that you're stretching the joints and that you're not putting tension on that tendon. So the way to do this is to put the tendon in a protected position. So you want the wrist to be in full extension, and all the joints that you're not stretching should also be in full extension. So you want the IP joints to also be in full extension. If the MP is stiff, then we're going to just gently work at getting that MP flexion back. And you also need to make sure that the patient understands exactly how to exercise so that he doesn't do any damage. He should feel tension at the joint, but he shouldn't feel any tension at the place where the tendon was repaired. Okay, and then patients like this often have a lot of adhesions that limit flexion. So because of the adhesions here, they might be able to move a bit like that or move a bit like that, but composite flexion is very difficult. So to resolve this, I find that it works really well to get them to block the MP joint in flexion and then work on active IP flexion. So you can see this lady trying that. It's quite a difficult exercise. Okay, and then with these patients, you're probably going to need to use resistance, and you may well need to introduce it sooner as well. Okay, so it took us 3 months, but this was the patient's result in the end. So you can see that's not looking too bad. He has pretty good extension. The index finger MP joint is a bit stiff, but he was quite happy with the results. You might also get patients who were referred 6 weeks or later after an extensor tendon repair. And if they referred that late, then I would say that the tendon injury actually becomes less important. You don't even need to protect it anymore. So what you have now is actually a stiff hand, and you can manage it like you would for any other stiff hand. Okay, then just briefly, there were a few people who also wanted to know what to do if the patient has a fracture of the metacarpal or proximal phalanx as well as the extensor tendon repair. So if you have injuries to multiple structures, it can be helpful to consider the precautions for each injury and then make sure you take all of them into account. Then it's also good to speak to the surgeon and find out how much movement he would be happy with of that finger that was injured. So it is hard to make absolute recommendations because the management is going to depend on various factors like the type of the fracture, the presence of other injuries. But in general, if the fracture was managed with rigid fixation, like a plate or screws, you can generally start with active movements after 3 to 5 days, and they're allowed full active movements at this time. So you can use relative motion extension splinting from the beginning then. But if the patient is managed with K-wires, then K-wires don't provide enough stability for unprotected active movement from the beginning. But after 2 to 3 weeks, when the surgeon is satisfied with the fracture healing, then he'll take the K-wires out, and then you can start with relative motion extension splinting. But you do need to be careful because you still need to follow the precautions for the fracture. So something like introducing passive motion earlier might not be indicated for these patients. Yeah, and then those are my references.
Wonderful, Nicola. Thank you very, very much. Can I ask you to show us that, for instance, initial scar Could you perhaps show us on the screen how you would do the scar massage for him? It's some, if you've never seen it being done, it's often hard to know how to massage in order to manage that kind of scar.
I usually get patients to usually a thumb is better to use, or they can use 2 fingers together because a thumb is a bit stronger, but if it's fingers, then 2 will be better. So I prefer the thumb. They need to press hard enough that the color of their nail changes. So you'll see if you press your nail hard, it will go white. So that's the amount of pressure that they want. If they complain initially that that's too painful, then they can start off putting a bit less pressure and increase the pressure as time goes on. And then I usually get them to put their thumb over that scar and then to try and move the scar around. So I literally show them. I show them on another part of their skin that, look, this is how much your skin is supposed to move. Now look here by your scar, how stuck it is. We need to get it to move like this again. And then I get them to put their thumb on that scar and to move it around. So you can do circular movements, you can do movements like that, movements like that. And then also what happens after a while sometimes is that the scar doesn't seem that stuck, but you'll see if they extend their fingers, then the scar will pull. And you can even get them to move their fingers while they're busy doing that massage to really get that scar loose again.
Great. Thank you very much, Nicola, for that very practical tip. Nicola, if you wouldn't mind responding to this question, any advice for the patient awaiting surgery? This often happens in our settings. Would you do protective splinting, such as a resting splint? Is any range of motion indicated? Often in our setting, patients wait up to 2 weeks for surgery.
It is a bit of a difficult one. There's not really guidelines on what to do here that I've found, because this isn't supposed to happen. So no one really writes about it or investigates what works best. So the one thing we do want to theoretically do is prevent the tendon from retracting as much as possible. So we do want to relieve the pressure on that tendon to some extent. So what I would usually do is make a similar sort of splint to what the patient would need after surgery. So I might still make them a relative motion splint then, but they don't have to be as specific with wearing it all the time. It's not like they're not going to damage anything if they take it off. But theoretically, wearing that might help the tendon to not retract as much. You usually do some sort of protective splinting like that, but still keep on doing active movement, because if they get slip joints while they're waiting for the surgery, which is probably what happened with the second patient I showed you, then it's going to be a much bigger nightmare later.
Thank you very much. Vicki, do you want to add anything to that?
No, I think that's she covered that very well. Like, obviously I'm in private settings, so I don't encounter too much delay. Or actually, to be honest, the people that don't go to the doctor early enough, then they are naturally delaying themselves. Yeah, but it's exactly that. It's the retraction that's hard, because then you're ending up with tendon transfer, not transfers, tendon, what do you call it? Tendon grafts.
Thanks, Vicki. Thanks very much for that.
Yeah.
And then interesting question. Have you ever tried or know of any research that tries a reverse yoke type splint for flexor tendon injuries with a wrist brace in neutral or flexion perhaps? Have either of you ever come across that? I
know that is an option. So the main thing with that is it needs a strong repair. And so you need surgeons who are doing 4-strand repairs for a flexor tendon injury. For an extensor tendon injury, the strength of the repair isn't as important, because the tendon doesn't have to injure as much. The muscles just aren't as strong. They're not going to pull as hard. But for a flexor tendon repair, if you want to do that, you need a strong repair. And it's generally only for FDP, flexor digitorum profundus, because that is the one with the common muscle belly. So if only FDP is repaired, then you can use that same theory that Vicki was explaining about the common muscle belly, where one tendon is placed on more slack. But with the FDS, it's not, as far as I know, it's not recommended with that, but it's not something I ever tried out before.
Yeah. Thank you very much for that, Nicola, much appreciated. And then just a follow-up question around scar massage. Do you usually use a cream, like aqueous cream or something with your scar massage? What do you recommend?
I usually get them to start with eye cream, because I feel like cream will make their thumbs slide all over the place and they won't get that tension on the scar. And then I tell them once they're done without the cream, then they can put some cream on, because we do need to moisturize the scar. Scars often go very dry, like scaly. So it's still important, but I usually get them to do that afterwards.
Great. Thank you very much. Vicki, want to add something?
No, I agree. Yeah, you have to massage without it first.
Great.
Yeah.
And then we have a question from for Nicola. Did you consider pressure garments with Vincent?
I didn't actually. His scar was not really raised or anything. It was really flat, but it can be a good idea for patients as well. So I do use it sometimes.
Great.
There's a question there that I can answer, I think.
Please go ahead, Vicki.
Yeah, it says if it's only the little finger or index finger, which splint can you use? So just, there's been a couple of questions, so maybe I wasn't actually clear there. So you can use it if it's just the index finger or just the small finger. The only time you can't use this protocol is if it's only the index finger that remains intact. So for example, if the repair is done on all three except the index, because you can't get the splint to hold the other three in place. So you can't get the one finger to hold three fingers in extension. There's not enough tension. And the same with the small finger. So if it was just an index finger or just a small finger, you can definitely use the same splint.
Great. Thank you very much, Vicki. We are ready to close. An incredibly big thank you with all the participants to Nicola and Vicki for incredibly clear and concise presentations. Thank you so much. And we are looking forward to our next webinar in October, on the 1st of October, which will focus on staying ahead of hand burns. So thank you very, very much. Please continue to follow us and link up on social media so that you are aware of the new webinars and any other information that is shared. Thank you very much for joining this evening, and thank you again to our presenters for incredible presentations and all the time and heart that you've put into this. We appreciate it, and our patients appreciate it. Thank you very much, everybody.